everyone. Thanks so much for joining me on the Slice of Healthcare podcast. I'm your host, Jared Taylor. Joining me today is Joe Benardello, the co founder and chief growth officer at IKS Health. Joe, how are you today?
Great, great. Really good, Jared. Hope you're doing well, and thank you for having me on the show.
Absolutely. Excited to have you. Let's dive right into it. Tell us about your background a little bit.
Yeah, absolutely. So, interesting background. I thought that I wanted to be a philosophy professor, and was in grad school, and a friend talked me into getting into technology testing. And I didn't really know a whole lot about computers, but he's like, you're into analytical reasoning. It's if then statements. Why don't you come and see how you like testing? And I did, and I liked it because it was really solving problems. And what that launched me into was a career that quickly took me global. So all of a sudden, I was testing technology that was coming out of Japan, and I was coordinating projects for technology that had to be developed into a whole bunch of different languages. And so I learned the intersection of globalization and the application of emerging technologies. I think early in my career, that led to a couple of jobs and a startup. The startup that I did ran from 99 to 2002. It was funded by a group called Ziff Davis and spun out and then eventually acquired by a publicly traded company up in Waltham, Massachusetts called Lionbridge Technologies. At Lionbridge in 2002, that was really my first exposure to healthcare. And it was such an eye opener for me when I learned just about all of the opportunities to bring efficiencies that had maybe existed in other industries, things that had been solved either through technology or rationalization of tasks or distributed work teams that really hadn't found their way into technology. And at first, I was just on the payer and pharma side. But then I got exposed to the provider space, and holy cow, was that an eye opener for me. When I saw just the chaos of the environment that the providers were being asked to perform in, and kind of the downstream consequences on care. And I think my partner, our CEO Sachin Gupta, worked at the same company, and that was the real eye opener for us. That there was an opportunity to take what we had learned in other places and really apply it to this emerging opportunity in healthcare.
Which became
Which
IKS
became
Health, right?
IKS Health. And so IKS Health, really launched in fall of 2006 and opened our doors in 2007. And the one experience that I think really shaped the company was something that we had done while we were still at Lionbridge. There was a healthcare company called Beverly, publicly traded at the time. Stock was trading in some $1.30, $1.25 range. And we were doing a significant amount of software work for them and realized that at dinner with the CFO that they had a real revenue cycle problem. They had a totally distributed revenue cycle, 1,400 locations, everyone doing its own billing and collecting. They had a very difficult time rolling up financials and reporting, thus their stock price. Long story short, we did a classic kind of centralization, consolidation, standardization of tasks. We wrote technology at that time that did a whole lot of automation. And then we brought in expertise to handle either the edits, the audits, the kickouts, and then also to drive insight into what was the behavior that would be exhibited at the homes that would change revenue cycle outcomes. Long story short, we took out about $17 million in costs. They were a couple $billion-dollar company. They were running a DSO in the mid 90 days. We took the DSO over 18 months to the high 30 days. Only 20% of that got written off. So it was a huge one-time cash infusion. long story short, remade the financials, tied it into some other smart things that the management company did. And they took that stock up to almost $13 a share before it was taken private. And I think that was the moment that my partner and I looked at each other and we said, the next time we do this, we're going to do this for ourselves. So, as I said, we opened in January 2007, 12 people, 25,000 square feet, and said, what would we do now? And I think from the start, we knew to focus on revenue cycle because that was the part of the physician continuum that was most, I think, easily understood to be done with a partner. We also thought that it was the single decision that could drive the greatest financial impact. So, for us today, when we do a revenue cycle opportunity with someone, we're saving about 35% off the cost to do it and driving, 2 to 4% increase in collections. So that was really the genesis. But the idea all along was this idea of how do we promote better, safer care? And the concept was we believed that practices were going to get bigger. And in 2007, we had just started to see some indications, but we thought it was going to happen. And unlike in the 80s and 90s, that they were going to stay bigger. And it was primarily due to technology that we were thinking that, because as more and more technology gets applied in the organization, the cost of infrastructure for every organization certainly goes down as you add physicians. And so, you kind of need the same operating infrastructure for a 5-doc group that you need for a 500-doctor group. You gain operating leverage at size. What we also were planning is we're big believers that there was going to be a transformation in how healthcare was reimbursed. And so we had an eye on value. And as we thought about if organizations are going to get bigger, if reimbursement is going to change, and then we looked at how technology was applied in healthcare today. And what's really interesting about technology in healthcare today, it's kind of unique compared to other industries in that as healthcare has taken technology on, it's created burden at the most discretionary, highest level worker in the value chain, which is the physician. Those organizations get bigger and industries consolidate, they kind of create this task pyramid. And on the top of the pyramid is that highest value, most discretionary worker. And what we found with healthcare was that even as healthcare technology was doing very valuable things and doing some things very well, it would also create work to be done. And that work to be done was falling on the provider. And so IKS, even as we were launching in the revenue cycle services, our concept from the beginning was a simple one. If a doctor doesn't have to do it, a doctor shouldn't do it. And if it doesn't have to happen in the exam room, don't do it in the exam room. And that concept of how do we make that space sacred? How do we make it intimate? How do we make it focused? I think has shaped our entire offering, because we cascade that now through the entire value chain of healthcare workers. If an MA doesn't have to do it, let's not make the MA do it. If it doesn't have to happen in the clinic, don't do it in the clinic. If it doesn't have to at the front desk, don't do it at the front desk. And as you start to break that, what you do is you disaggregate task into 2 chunks. There is the core task. And the core task is really the essence of what makes a provider a provider. It's why you go to medical school. It's why you become an MA. It is the things that only that you can do. And if we can start to allow our providers and our provider organizations to focus on their core, what is that? It's provider wellness. It's your growth strategy. It's your payer contracting strategy. It's patient care. It's pathways. It's those types of things. And then you start to think about what are the chores? Well, it's certainly revenue cycle, but it's documentation, it's population health, it's digital health, it's making sure that the right information is at the right EHR at the right time. All of these types of really necessary force multipliers. And IKS becomes that through a combination of, again, standardization, centralization, and optimization, which is a combination of technology with expertise. Because even the technology that we bring creates tasks to be done. And we want those tasks to be done at the right area of the value chain. And so that was the real concept and journey of the company. Today, we're providing services for about 35,000 physicians, a little over 6,000 employees, based, at our centers in the United States and wholly owned centers in India. And for our clients, they are some of the biggest enterprise names in healthcare. So if you did a search for us on the internet and we're looking at the Boston Globe, you'd see articles about our impact at Mass General. Or if you're looking in New York, you'd see impact of what we've done at Caremount, which is an Optum provider. But that idea of how do we protect the patient physician encounter to drive better, safer, and more efficient care. And I think that efficiency point is also critical, because for us, efficiency is sustainability. There's lots of things that you can do to provide better, safer care, but if it is not efficient, it's not going to be sustainable. So probably pretty long answer to a direct question.
No, I love it. Thank you for that overview. Really helpful. I want to shift our focus, if we can, to a topic that I think a lot of us hear a ton about, provider burnout.
Yeah.
Maybe give us a snapshot of what you see today with provider burnout, and maybe where it's trending, and maybe what. Don't give us the secret sauce, but what needs to be done to improve that.
I think that it's evolving, but for me, provider burnout is as much about meaning as it is about workload. Because I've watched and shadowed too many providers in my day, and as I've watched them, I just see how many tasks that they're forced to do that are absolutely necessary in the production chain of healthcare, but that the doctor is doing them is not bringing any value to the doctor or the patient. And so one is provider burnout is what we're asking our physicians to do. And the second part of it is how much we're asking physicians to do. So, if you think about documentation burden and the 60 to 90 minutes a day that doctors are spending on the EHR every night, that is hitting doctors both in terms of time and meaning. When you think about inbox management and all the noise that are coming through and all the things that they have to click through, it's not just time, but it is meaning. And what we found is when we offload some of those mission critical but not provider necessary tasks, like handling their documentation or reducing their inbox volumes or doing a pre-visit summary that tees them up, providers work more. Providers really like to care for patients. I mean, that has been one of the delights that I've noticed. So for me, provider burnout is both reducing the scope of work while allowing the provider to accomplish more. And what I've seen time and time again is that provides energy. And what's very interesting is, we have a solution called Scribble, where we provide a microphone on the form of a tablet that allows the physician to practice naturally. We run that visit through our technology and then have clinicians look at it, do all the documentation. That is a huge provider productivity, documentation, which drives reimbursement, improves vehicle. It's a huge provider burnout vehicle. What's interesting is that there's it's almost a 92% correlation of either the Press Ganey scores or the NPS scores for that provider patients as they rate that experience. And so the patient is enjoying the visit more. And why they are is because a provider that has burdened less is a happier provider, and a provider that isn't pecking away at their computer is someone that is empathetic and communicating and involved in that interaction. So it's really interesting to see the correlation of, we pull some of the chore off the provider, allow them to focus on the core, and that energy then translates to the patient encounter, which is critical, not just in fee-for-service medicine, but when you think about value-based care, when you're trying to affect somebody's behavior, You're talking to someone about, hey, how are we going to manage your smoking, or what are we going to do about, diet or any other stress related lifestyle changes. To have someone that is communicating to you and invested in you rather than managing a piece of technology, I think that addresses burnout in a really significant way, in a way that's benefiting everybody.
Absolutely. Thank you. I'm always really curious about that topic because we hear about it all the time. Um, if you set a Google alert for provider burnout, you'll quickly turn it off because you'll be overwhelmed with how many
Yes.
alerts you get.
Yes.
Uh, what if we can move on to something else I really wanted to talk with you a little bit about, and it's this the interplay between tech and staffing shortages. So we talk about provider burnout, but another topic that we hear a ton about is staffing shortages, both within, it's not just health systems anymore now too, right? It's in virtual care.
It's
It's
out everywhere.
everywhere.
Yeah. And so go ahead.
Oh no, I was just gonna say, yeah, would love to hear your thoughts on that interplay, and then kind of maybe how one affects the other and where we're heading.
Yeah, so I think that there is, the exciting news is that there is a significant amount of technology that is disrupting what were formerly people-heavy tasks. There are things that you can do for check-in and scheduling, and benefit verification and really establishing that. I think that there is certainly the move to virtual visits, which has been a kind of an interesting adoption curve because we saw it really go up during COVID, and all of us said, the sea change is here. And actually now the tide has gone in the other way, and as we come out of it. But I think the important thing about all of those elements of technology is, one, how do you artfully insert those into the workflow? And I think there's enough examples that we can probably all think of that I won't pick on any company, including my own here, but where we've developed something that is really great, but we haven't quite thought, like, how does this fit neatly into a provider team's workflow, and not just the physician but that whole team, right? And it is a team. It's a team that gets the patient from the parking lot through the front office into that room, back out, and home. And so, where and how do you stage your technology interventions? And your technology interventions are going to create some work to be done. Now, what's interesting about that is technology will do most of the stuff that is repeatable, rules-based, programmatic in nature. And what it's going to leave is discretionary tasks to be done. And so, it will effectively raise the skill level on the folks that are left, and the consequences of attrition in a higher skill level environment are also going to be more severe, because then there's going to be a higher job learning level. The other component is the backbone of so much of healthcare, MAs on down. You're competing now with every practice in the country, but really every industry in the country. That is a sweet spot of a service industry worker. And so if you can't figure out a way to use technology, and for us, a big part of the answer is industry trained remote expertise, then I think that you are going to continually be fighting a battle of not only filling the seat, but filling the seat with the right skill level. So our solution of it has been leverage the existing technology footprint of our clients and make their technology work better through a couple of different ways. One is by becoming the executioner, or the execution engine, maybe not the executioner, of the significant tasks that accumulate, And if we can leverage that technology to do those tasks either in Dallas or Chicago, or do those tasks in our facilities in Mumbai, all the better. But also, as we're doing that, we're bringing in our own pieces of technology that are really EHR, pop health tool, practice program management, or practice management software agnostic, that are also providing this technology layer and bringing a different level of horsepower to those applications. So for us, I think technology both reduces the need for having so many people in healthcare, but then raises the consequences in the bar for everyone that you have left.
Great answer, Joe. Really appreciate hearing your thoughts on it. And thanks for giving us also, which is very difficult for people to do, giving us your thoughts on it overall and not teeing up as much as I know IKS can help with most of what we discussed here today. Not making it promotional and just explaining your genuine,
Yeah,
thoughts
I'm
on
on
it. So really
fire about
appreciate
the
that.
idea, and
Love it.
and I know that we're bringing real value every day to the 35,000 providers that we support. I know that we're making it better for their patients, and I know their organizations are better off financially. I don't know that we're the only people that do this, and I don't know that we have the only answer to this, but I believe in our answer. But I'm on fire for the problem, and get excited that I get to solve it.
Love it. Well, Joe, again, I want to thank you so much for being a guest on the Slice of Healthcare podcast. Hopefully, we can have you back on again real soon. And wish you and IKS Health the best of luck.
Hey, thank you, and I appreciate the work that you're doing here, and starting the discussion and continuing the discussion on these important topics. They can feel overwhelming, but we believe that there are pragmatic solutions that can really bring value today, even as we wait for the tricorder, world of tomorrow. The intermittent steps. There's just so much value to bring. So thank you, and appreciate the work that you're doing.